solid.
It's solid.
All right.
Is it supposed to flash?
I don't think so. I think the light's good.
Are you okay?
I'm all right. Maybe. I don't know. It's been a long day.
Oh, I'm so sorry to bring you out here today for this.
No problem. My pleasure.
Is it?
It is.
Yeah.
Well, ask me in 20 minutes.
Yeah. So I think we started this topic on understanding the patient, and you've heard me present this I don't know, at least 5 or 6 times, on understanding the patient using this perspectives of psychiatry model. And you had a couple of really good questions about it. Because I pretty much said that when you assess someone, you think about them in 4 different quadrants. A disease is what the person has, dimensions is what the person is, behavior is what the person does, life story, is what the person encounters, right? And you're like, well, what do I do? How do I ask this? Does everyone know this? Is there a survey? Is there a scale you can fill up? All that kind of stuff. And I gave you vague answers like, oh, well, Tim's doing it in his clinic or whatever stuff, all that kind of stuff. So let's go through any questions you have about those 4 quadrants.
Yeah.
And I'll try to be as authentic and direct as I can. And I'll try to answer the question without being too vague and all over the place.
Okay. Yeah. So no, just a few questions about what a psychiatric assessment is. This, do I have the term right? Is it a psychiatric assessment we were speaking about?
Yes.
Okay. And is a psychiatrist? So I know that some physicians provide psychiatric care. Is that correct?
Yes.
Okay, so psychiatric care isn't just provided by a psychiatrist?
Yeah, so if you're at a place where there's no psychiatrist, family doctors can do it. NPs do psychiatric assessments.
Okay.
Nurse practitioners can. You have to stay within your scope, but sometimes if you look at what a psychologist does or other practitioners, there may be a lot of overlap.
Okay, so and this assessment, is this something that has a table that goes to it, like that you score? Is there a scoring table that goes with it, or a scoring sheet? Like these answers mean something, or the answers in and of themselves are? Yeah,
so not the way that they teach it, right? So this book here is a step-by-step guide to applying the perspectives of psychiatry, right?
Okay.
And it's one that we've sort of linked. And the reason that they have this book is because the older one, people didn't know how to apply it.
Okay.
Right? And so I think the way that I think about this book is you do your standard psychiatric assessment, and if you want, at some point we can go through the specific questions, how we would ask them, all that kind of stuff. And then you come up with a diagnosis, you come up with an impression where you describe what's happening, you come up with treatment recommendations, you sometimes have a differential where other things it could be if you're not sure. And this is a way of what we call formulating the patient.
Okay.
Right? And so when we see a patient or when we do an exam where we do an interview and then someone's examining us on us, we have a section where we formulate the patient. So we have to describe how we understand what the person is currently going through when you look at them in the context of their life.
Okay.
And historically, in psychiatry, we use something called the biopsychosocial model. Right? So biologically, what's happening? What are they experiencing socially? How does that affect them psychologically? And things like, someone's parents who weren't there for them, and so they do things independently, and it's hard for them to ask for help. That would come up in there. Because you wouldn't see that in a diagnosis or treatment recommendation. It comes up in the formulation.
Right.
Another example could be that, somebody was bullied as a kid and then they don't trust anybody, and so they don't really form relationships and they keep to themselves.
Okay.
Right? So does that make sense? That sometimes
that makes sense, but I guess it's as you know, but maybe other people don't. So I worked on a team with on a floor in the hospital, or I still do from time to time, which has a number of psychiatrists on it, has some family doctors on it, and there appears to be a big, and some NPs on it, and some addiction service, some not addiction service. So I just wonder how this the psychiatric evaluation that we're talking about fits into kind of everyday addiction care, right? And is this something that should be applied into kind of a RAM clinic, for example, right? Or is psychiatric care being applied in that model?
Yeah, and so I think the thing that and I'm trying to present the proper context, right? Because it's I want to make sure I make it clear, what this is. So there's a standard of what basic addiction medicine is. There's a standard of what primary care is, or family doctor, family medicine. There's a standard of what psychiatric care is in terms of the assessment and treatment recommendations. And within that psychiatric care, sometimes you have a formulation. This is a slightly different way of formulating or understanding someone than what we would typically do.
Okay.
Does that part make sense?
That makes sense.
Okay.
Yeah.
And in real life, when you see someone in a RAM clinic, a rapid access addiction clinic, it's very hard to have an hour-long visit with that person.
Right.
Right? And so it may be something where you don't do all of it. For me, the reason why I teach this and I talk about this and I share this is because I think there comes a point where it's not just withdrawal, it's not just anti-craving, it's not just buprenorphine, it's not just housing. And you want to try to understand the person as a whole.
Right.
What have they been through? What's shaped their life? Why they look at things a certain way? What's their personality style? What's their temperament like? What healthy or unhealthy patterns of behavior they've gotten through? What kind of diagnoses do they need treatment with? And the reason I teach this is I want people to think broadly. And what your question really made me think of is that what use is it to tell everyone to think broadly if I don't tell them how to do it? Like, it's like me saying, like, oh, just think about somebody's cultural background and their family and this and that. And sure, they can think about it, but if I don't give people a structured way to do it, how are they going to apply that into their practice?
Well, sure. And I mean, give them the structured way, but also, I'm also a realist here, and we're, living in 2022 here, and the healthcare system is a little strained where we are. I think that's could be agreed upon. And the resources are such that addiction care, that's what we're talking about here, is addiction is given in the real life. It's given in either a kind of a 3 to 5 minute assessment in a methadone clinic perhaps, or a 10 to 15 minute session, and that could be long in some of our RAM clinics. So is any of this getting addressed in that, or are we just talking about a theory, something to aspire to, but we don't really ever get there?
Yeah, I think unfortunately or fortunately, I think it's more of a theory on what to aspire to.
Okay.
And I think the part where it becomes more relevant is once someone has been showing up a little bit more regularly, they're given the basic standard of care, and they're not getting better, right? And that's where I think there's definitely need to bring in that breadth of understanding. If I had to simplify things a little bit here, another way that I might look at it is that you have this rapid access addiction medicine clinic, and you might have a peer that sees a patient.
Yes.
There might be specific things that the peer does.
Yes.
You might have a caseworker that sees a patient. There's specific things the caseworker
100%.
does. Then you have a nurse that sees a patient before the doctor does, right?
Yes.
And then the nurse asks through a couple of different things.
Yes.
And then you have the addiction medicine doctor that does a bunch of things.
Yes.
And then you might have down the road a comprehensive psych assessment that's like an hour and a half.
Right. Right.
And all of them are seeing somebody who uses drugs, and they're all doing very, very different questions. And I would argue all those things are important for different reasons, and some of the stuff might overlap and some of the stuff might not.
Yeah. So I can't speak to what happens in that psychiatric 1 hour assessment when it happens, but I can speak to what happens in the 5 steps.
The other ones I said
before. The 5
before.
precursors that you mentioned, right? And unfortunately, where I think we got to up our game a little bit is we ask the same, all 5 people end up asking the same questions, to the point where by the time the patient sees the doctor, they're like, very like, at
They're
the
done.
end, they're done. They're
Like,
done.
let me
They're
leave,
checked
please.
out. Yeah.
Let me leave.
Don't ask me this again, right? And unfortunately, sometimes even the most skilled of us seem to stumble into soliciting an answer that deals with these patients' traumas, which is so difficult, right? And that, can you imagine, not only is it so difficult, but you have to do it 5 times, right? So that's where I think we need to, I certainly need to work on asking questions that doesn't end up triggering that, right? That's where, it's really hard. You don't know what's gonna lead somebody where, right, as to what they're going to share.
Yeah, so that's a different question. Like how do you ask about someone's trauma? But that's a very good question. I mean, that's something that, that's
well,
something
we try not
about.
to, is the point. right? Not in these sessions that are 10 minutes long, right? That's not that's
I
not
agree
the
with
point
that.
of
I agree
it.
with
So,
that,
but if we stumble on it, then I see it as a bit of a failure. And if we stumble on it 5 times, then we haven't done a great job.
Yeah, no, that makes sense. That makes sense. So I think there's a few ways to go here. One is we could keep this sort of Q&A going, where if there's something that you want to figure out, we can try to figure that out. I could describe a psychiatric assessment, but it would be like a 10, 15-minute talk.
Give me some questions. Give me. You must remember 3 questions or 4 questions of the psychiatric assessment.
I know the whole assessment.
Oh, okay.
I do this every day.
Okay.
I do this like 4 or 5 times a day sometimes.
Well, can you pretend I'm the patient and ask?
I don't know about that, right? Because I don't want to. What if you start giving me real answers?
Well,
right?
I don't know. I guess we'll see. Let's see what happens.
Yeah. Nah.
Well, I'll make up the answers. How's
Why don't
that?
I just describe what the questions are?
Why don't you just tell me what the questions are?